Hello and welcome to Break the Chain, Depression's Link to Hospitalizations. We appreciate so many of you joining us for this special webinar presentation today. First up, I'd like to introduce to you Cynthia Pammon Burnett. Cynthia is a registered nurse with years of experience in healthcare. Currently, she serves as the Centers for Medicare and Medicaid Services Program Lead for the QIO programs Improving the Health Status of Communities initiative. She is also the Government Task Leader and Subject Matter Expert for HHQI. Cynthia is a certified case manager and also has a Bachelor's of Science degree in nursing from the University of Illinois, as well as a Master's in Healthcare Administration and a Master's in Business Administration from the University of Maryland, University College. It's my great pleasure to turn things over to Cynthia Pammon Burnett.
Thank you, Shannon, and hello, everyone, and welcome to the webinar today. I am so pleased to have Dr. Bruce present today on the Depression CAREPATH strategy. We certainly recognize the importance of this work at CMS, and I know you will find it very helpful for those home health patients who may benefit. So therefore, without further delay, I will turn it back over to our facilitators and presenter, and thank you very much for attending.
Thank you, Cynthia. During today's presentation, you will be able to describe the purpose and rationale for using the PHQ-9 Depression Assessment Tool. After the webinar, you'll also be able to explain how the use of a depression management protocol can reduce hospitalization rates. And third, you'll be able to identify 2 ideas or tools to improve your clinical assessment or patient care plans for depression management. Today's presentation includes 1.25 hours of continuing education credits for free for nurses. These credits are approved by the Alabama State Nurses Association, an accredited approver by the American Nurses Credentialing Center's Commission on Accreditation. During today's presentation, you'll have the opportunity to submit your questions using the chat or Q&A feature in the WebEx at any time. Note that you may need to click on the chat button at the top in order to access this feature. We'll get to as many questions as we can at the conclusion of today's keynote presentation. Now it's my great pleasure to introduce to you Dr. Martha Livingston Bruce. She is currently a professor for the Department of Psychiatry and the Dartmouth Institute Geisel School of Medicine at Dartmouth College. Her formal training from Yale University includes a Master's of Public Health related to healthcare delivery science, a PhD in medical sociology, and a postdoctoral research fellowship in the field of psychiatric epidemiology. The focus of her research is improving the care and outcome of depression in non-mental health settings that care for older adults, such as home health, primary care, and aging services. She has more than 225 peer-reviewed publications. She has been continually funded by the National Institutes for Health for almost 19 years at Cornell and Dartmouth to work in partnership with home health agencies with the goal of improving detection, management, treatment, and outcomes of depression in geriatric home health patients. These partnerships have led to developing feasible, acceptable, and effective strategies for nurses and other clinicians to integrate depression screening and management into routine practice. Results of these initiatives have been published in high-impact journals. At this time, here is your keynote presenter today, Dr. Martha Livingston Bruce.
Thank you, Shannon, and thank you, Cynthia, and thank you, Misty. And I'm also just going to say from the very top, thank you to the many, many home health care nurses, agencies, administrators, and patients who really have helped me and my colleagues in this work for over 20 years. And so my entire goal has always been to do work that was had meaning in home health care and would be useful. And I'm happy that to be able to give this talk today because it's just that some of this is coming true. let me see. So I'm going to disclose that all my funding is coming from the National Institute of Health, and start by pointing out this best practice intervention practice, the BPIP, that the Home Health Quality Improvement have published on depression management. Pretty much everything I'm going to be talking about, especially in terms of tools that you can be using, can be found in the BPIP, and we'll go over some today. And we have website resources and other resources that can be helpful. So I'm just going to point you in that direction and go from there. The way I've organized this talk is to begin by talking about a little bit again about thinking about what depression is, why it's a problem, especially in home health older patients, and then some of the impacts it can have on the kind of outcomes that home health is most concerned about. Then look at the evidence saying that interventions in depression can be useful and helpful in negating those outcomes, and then from there get into some of the details about some of the strategies that could be helpful. So, start off. I'm going to start with the simplest question, which is what is depression? And on the one hand, we all know what it is, but on the other hand, it's a term that we use every day. We're talking about having a bad hair day, so I'm feeling so depressed and down and blue. But when we're talking about depression, as you all know, in medical settings and nursing settings, we're talking about something that is clinically meaningful. Major depressive disorder is 5 or more persistent, and that's kind of a key term, persistent symptoms, one of which is depressed mood or loss of interest or pleasure. That's called anhedonia. And these symptoms cause distress and impairment. Minor depression is the same thing with fewer symptoms, and then there are lots of people who have symptoms that are part of the depression complex that might not make these full criteria but can be meaningful to people. So, depression and home health, as this is from the BPIP, CMS has put increasing emphasis on depression and depression management, and as you all know, they've got extensive tools now in MOVE 1730, including the PHQ2, and I'll talk about that later. And then other moves about talking about plans of cares and interventions. When I started this work, and we're talking quite a long time ago, and I think it was actually before the OASIS, but when the OASIS-B came out, depression symptoms were there, but they were kind of barely there. And it's been a great pleasure to watch CMS and the fields really become more and more recognizing that depression has meaning in their work. So when we did what we'll call an epidemiologic study, we took a random sample of a big agency and went and did home clinical interviews, and we had psychiatrists adjudicating the results. We found that that 1 in 7, 14% of these patients, these were Medicare Home Health patients, met full criteria for major depression, and another 10% met criteria for minor depression. In other words, we have 25%, or 1 in 4 of the home health patients meeting criteria, and obviously more had additional symptoms. To give some perspective, these rates, both of them, are twice what you find in primary care older patients using the same techniques. So this is not a rare problem. This is a very common problem. Now, when this work started 15 years ago, very few patients were referred to home health with a diagnosis of depression, and depression was rarely mentioned as a concurrent diagnosis. And when you looked at what we saw, our clinical assessments, and what was reported in the OASIS, really only 35% of the patients that we thought were depressed were noted as being depressed in the OASIS, and only 22% of those patients were having any depression treatment. Things have changed over the last decade and so, and now you still don't have a lot of patients being referred with major depression diagnosis, but you see twice as what it was. And as we just said, and we'll continue to say, the OASIS gives far better guidance in the assessment of depression. I think that the biggest change has been the rate of antidepressant use, and almost 3/4 of the patients who have depression are now being treated with antidepressants, usually only with antidepressants, not with evidence-based therapies. And I think what's probably more remarkable is over 1/3 of all patients, regardless of their reported symptoms or their diagnosis, are starting home health care already taking antidepressant medication. I think that's a reflection of increased awareness of depression. It's also a reflection of the safer medications available for depression, the antidepressants, and it's also somewhat on the more negative side, a reflection of good marketing by the people who sell them and much more awareness by primary care clinicians that antidepressants can be useful, potentially useful, and so they're prescribed quite freely. But I think it does mean that any home health clinician is going to have to be aware that antidepressants are going to, one in 3 times, the antidepressants are going to be in the mix of medications that their patients are going to be taking, and that should be considered in the whole clinical package. I think what's important also about these high rates of antidepressant use is there's 2 sides of it. One is that just because a patient is taking an antidepressant doesn't mean that depressant symptoms that they report are not positive, are not important. I mean, it's really easy to say this patient is reporting depressive symptoms, but she's on an antidepressant, so I don't need to worry about it. And I think you could flip that by saying if you have symptoms, if you're taking an antidepressant for any time at all, and symptoms persist, that's an indication that the antidepressant, the way at least is currently dosaged and being delivered, is not working. Either there's no compliance, or it's the wrong dosage or the wrong type, and management is needed. So just because antidepressants are being taken doesn't mean the problem is solved. And in fact, if you have symptoms and antidepressants are being taken, then actually the problem is really one of management. I think, as I said, a third of patients who are getting antidepressant treatment, and this is in home health, but this is pretty much true in primary care too, are that the antidepressant treatment itself is not being well managed, and then meaning that rarely happens, often happens, is that a clinician will prescribe an antidepressant, perhaps thinking start low and go slow, but never following up and seeing if the dosage needs to be changed, if the actual medication is the right one, if we need to augment. And I think the problem now is less, we don't miss depression, and it's less that we don't get people started on treatment. It's really much more that treatment is not being managed well, and therefore they are not getting better. I think it's important to say, we know that people who have depression are suffering. There's also an impact on other outcomes that are important. This is from my epidemiologic study that shows that people who were home health patients who were depressed had now greater ADL decline over the course of a year, so they were at a greater risk of decline. This is among patients who have serious falls in the home health records versus those who don't, and the patients who fell were really twice as likely to have had depression noted in the OASIS. And probably most importantly, there's different evidence from different places all saying that patients with higher depressive scores, in this case it's the PHQ2, have a greater likelihood of being discharged to hospital. We'll talk about the fact that the cutoff here is 2. The rates of hospital discharge in this big study, it wasn't a study, it was all the records from all the patients over the course of the year in a New York City agency. The rates of hospitalization were the same for people who scored 2 on the PHQ2 as those who scored 3 or above. So again, this is to say that depression is meaningful to the patient, meaningful to the patient's family, to the clinician, and to agencies and society. So we're going to be talking about ways that home health can intervene or improve the management of depression during home health, and one of the first questions is, if we have a chain between depression and the outcomes, such as hospitalization, will these interventions make a difference? And so I'm not going to report on these outcomes before we get to kind of the, as I said, get to kind of the nitty-gritty of what are we doing. But I think it's important to see that we can do things. What I'm talking about is the program of intervention strategy that I've developed with my colleagues and my home health partners from around the country. We call it the Depression CAREPATH, which is depression care for patients at home. It's in the BPIP. We have a website that anybody can access for training. I'll talk about it a little bit later. But basically, this Depression CAREPATH has two major components. One is assessment, screening and assessment, and the other is ongoing management. So what assessment? We early on realized that we couldn't do any interventions around depression until we helped home health nurses really understand what depression was. And the results of this study, where we developed a training and we randomized nurses, and we had several cells, but the most important ones were those who got our training and those who didn't. And this was before the PHQ was in the OASIS, but it was taking the basic symptoms of what does it mean by someone is depressed? Can you, based on your clinical skills, sort of understand what that complexion is? And we found here over on the left that if we trained up nurses, in this case, to understand what depression is, well, if you had a bunch of people who we didn't think had depression, they were no more likely to make any referrals or do anything different with those patients. And that's important because it meant that we weren't training nurses to flag depression in people who weren't depressed, because that's not going to be helpful for a lot of reasons. But it also meant that over here on this side, on the right, that the nurses who were trained to understand and to identify depression and to make a referral in this case, really they more than doubled their rate of being able to identify the right patients needing the right care at the right time. And that was very satisfying. So then we've further developed the Depression CAREPATH beyond the screening and the assessment in terms of ongoing management. And just so you know that we actually did a randomized trial of this work. And what we did was we trained the nurses in the intervention arm basically about the Depression CAREPATH. We worked with the IT systems of different agencies, and then we provided long-distance consultation with the nurse supervisors, which is to say, this intervention, we were pretty far away. We were sitting in New York, and people were, I'm having a hard time clicking. There we go. But people who were doing the trial were in different parts of the country. We had agencies in Miami and Arkansas, outside of Detroit, Philadelphia, New York City, and Upper New England, New Hampshire, and Vermont. And so all the real work was we were in New York doing our New York thing, but all the real work was being done by these agencies around the country. And what we found is that in patients who were screened positive for depression and had clinically meaningful depression, that over time, patients who, this is called the Hamilton score, the HAM-D. It's one of the depression measures of severity that's used by a lot of clinicians. And a score up here means these people have clinically significant depression. And the red lines are showing that the patients who are under care of nurses who are in the CAREPATH arm got consistently better, faster than, and sustained over time for a whole year. This is really important. This was a clinically meaningful change. It was a change in depression severity that persisted over a year, which is quite phenomenal. And we can talk about why, and I will talk about why. I think in part it was, I think that many of you know, obviously, a lot of these patients were not in home health for very long. They weren't in for 3, 6, 9, or 12 months. They were in for 30 days and 60 days. But what the nurses were able to do was to identify patients with depression, flag the depression as something that was important, not just sort of a sidebar, and be able to work with the patient's clinicians and the families to and I like to call it jiggle the system, is to help patients get on the right course to helping them get their depression resolved and do better over time. And so in this case, home health, it made a difference during the home health stay, and it made a profound difference over time. And I think, again, I think that the nurses who learned about the depression CAREPATH and knew what to do, and really sort of did a course adjustment for patients which is very important. Equally important that if you look at, this is a comparison of the CAREPATH, what you see as usual care, that the amount of length of stay of the patients in the two different groups wasn't different, and the number of actual nursing visits wasn't different, and the amount of time that a single nurse would stay in the patient's home wasn't different. Then you think it was lower. So what this means is that I strongly believe, and here's evidence saying that home health clinicians can integrate depression management into their routine work with everything else they're doing and do it in a way that is effective but does not add burden to their already very intensive work that they have to do in their work responsibilities. And this is the same study, and now we're looking at, regardless of people, the research project, 755 patients who screened positive for depression. In this case, think a score on the PHQ2, and those patients, let's see if I can make sure we can show it right, that the patients who were in the red is, where did that go? Well, the red is the CAREPATH patients. Patients under the care of CAREPATH nurses had the rate of hospitalization was 15% compared to the 22% in the usual care patients under usual care. And for 60-day hospitalization, it was 23% versus 29%. So this 30-day hospitalization, which is when the biggest impact of depression on the risk of hospitalization in home health comes very early in the course of a stay. You see it most pronouncedly in the first 2, 3, 4 weeks. And these data show that if you address depression in a way that's not a burden to the patient, to the clinician, but takes it into account and brings it to awareness and talk to the doctor about this, then you can actually see a result in terms of the risk of hospitalization. I will say that I think it was, I'm not sure how many years ago, but it was at least 10 years ago with someone who I knew but worked for CMS and had said to me, yes, your depression work is wonderful, yes, but I really am not going to really care unless you can show it has an impact on hospitalization. So part of this is my saying, yes, it is important, but it also is important for the things that are meaningful to the people who do the funding and the people who do the administration, that it's important to the patient, but it's also important for these other outcomes that are so meaningful. All right, so the question was how can home health care break the chain? And all right, let me just make sure that I think we saw those slides. So as we said, really the CAREPATH, and that's what I'm going to talk about now, is like how do we get to these results. The CAREPATH involves both assessment and ongoing management. And I'll just say from the start, assessing depression in older adults is not always that easy, and part of it is because of the way our society thinks about aging and older adults. There's this belief that somehow depression is normal, that somehow normal, therefore you don't have to worry about it. It's an acceptable part of aging, and that's a myth that we have to keep fighting. There's a myth also, and I think you don't see it as much, that reflection is a reflection of poor moral character, that people, or that can't be treated. It also gets confusing because of the misattribution of physical symptoms to depression and vice versa. And then depression, especially in older people, can sometimes not look so much like sad and blue. Actually, it often doesn't look sad and blue. It looks more like lack of interest in everything, or even irritability. And some of our most really challenging patients, and the most irritable patients, are part of that picture is coming from depression. and often it can be coexisting with anxiety or pain and cognitive impairment. So it's like everything else in the kind of patients that are receiving home health care. It's not a simple picture and becomes challenging in doing the assessment. The BPIP lists a number of ways to assess depression. They're all evidence-based and all really useful. The PHQ-9, the PHQ2 and 9 is one that's grown in great popularity for a number of reasons, especially in medical care. And so one reason to use it, again, is that many physicians know about it. But there are others. The geriatric depression scale is well known and liked because it's a simple thing. You're not asking people anything complex. You're asking for yes and no questions. The Cornell scale, the CESD, the Hamilton is one that's rated by the clinicians. And then, of course, the BPIP talks about other types of assessments that are very useful for other types of mental health problems, anxiety, PTSD, and so forth. Our training, and this is a snapshot of the website where we have training that involves showing clinical vignettes of using the PHQ2 and the PHQ9 as well as the depression care management. It's all free. It's all available. We put all this training in the context of a screening protocol where you begin by conducting an assessment. Typically, you use the PHQ2, which is on the MOOC 1730. Let's see, whoops. And I'm going to go back there. Well, there's a great little circle that comes up and says that if a patient scores PHQ score of 3 or higher, and I would even say 2 or higher, to go ahead and conduct a full PHQ9. This is, as you know, the PHQ2 really is looking at anhedonia and feelings of hopelessness, sadness, depressed mood, and anhedonia. The reason I've talked about using the PHQ2 is that there is research that in medically ill seniors, the PHQ2 is meaningful. I showed you the hospitalization data. And I think it just gets misused in home health, and that's why you find rates of depression using the PHQ2 in the home health data as under what you'd expect. I think because, let's see if I can bring it up again, so much of the OASIS is sort of a yes-no, click 0, click 1, that I think that a lot of clinicians, when they're doing the OASIS, kind of say yes, no, and don't think about the 2s and 3s. And it's also sort of complicated to ask older adults about this level of complexity of several days and how many days and half the days. So what ends up is even when patients really are feeling symptoms of depression all day long, every day, you might end up with a click on a 1 and a click on a 1 and a score of 2. So I think that it's worth noting either to decide as an agency that, you know, we're going to take the people who scored 2 as seriously, or to work more with clinicians in how to use the PHQ in a way that gets the kind of flags the patients that you want to flag. I don't think the circle is going to come up. So when you have a patient who scores 2 or 3, you conduct the full PHQ9, and the full PHQ9 will tell you a score that tells you when to move on to depression care management. And basically, patients who have a low score, in this case under 10, and no suicide ideation, basically don't need active depression care management, though you might want to keep your eye on them. Patients who meet the score of 10 or suicide ideation really would go into active depression care management. Oh, there's my circle. Anyway, here's the PHQ9. I think many of you have seen it. It includes the first 2 items of the mood depressed mood and anhedonia, but also asks the other questions that are consistent with a diagnosis of depression about fatigue and appetite, feeling bad about yourself, concentrating, moving slowly, and also thoughts about feeling better off dead or hurting yourself in some way. I'll talk about that in a minute. some people don't like asking that question, and actually some organizations just go through 1 through 8. I think in home health care patients, it's an incredibly important question to ask about people, how their thoughts about death, because many are ill, and depression, feeling that they'd be better off dead can really get in the way of people wanting to improve and get better. This is the way that the people who developed the PHQ-9 organized it. They said under 5 is no depression, 5 to 9 is a little bit. Anything from 10 or above is worth managing. You get higher, of course, the depression gets more severe. And we say that once you have a score of 10 or more, to start the depression intervention. Now, as I said, we have this item 9, which asks about, wish you were better off dead. And I think that this is the first step in screening for suicide risk. And in my own work, we find that the prevalence of suicide ideation, people who are really not just thinking about death because that may be something in their nearer future, but people who are wanting to die or even wanting to do harm to themselves, the prevalence is very high in home health, and I'm sure all your clinicians meet people like that and want to know what to do, but you also want to know, when to do something, actively intervene, and when to just note it or give certain types of comfort. So I would say the very first thing you should do before you have people asking about questions about suicide risk is to make sure that every agency has protocols in place, so that protocols to look at what kind of level of risk, what do you do to protect patients in safety, who do you call, what do you do for emergencies. Our website has a bunch of information that can guide people in developing suicide risk protocols. We also have training on how to ask questions and evaluate the severity of risk. This is the kind of spectrum we use where we thought, well, what do you have when you have what do we mean when we have recurrent thoughts of death, but we're not really wanting to die or be actively suicidal? What do we think about active suicide or someone with who really has an intent to plan? And we link all these kind of levels of gradation to actual behaviors and activities and what each clinician should do in the home. We started this is because when we first were working with our agencies, we had one agency who had no plan at all in place and didn't realize its importance, and another agency whose plan was if someone started talking about death, they should call 911, which is almost as bad because it doesn't, that isn't a real solution either. And so we've really had success, I think, in working with agencies, each agency to develop its own plan that's consistent with its resources and have people trained in those plans. So here's our protocol. Here we are, the patients who are either scoring 10 or above on the PHQ or indicating suicide risk. And from then we'll talk about the interventions. Now, when we started working developing the Depression CAREPATH, the Depression Care Management component of it, it was really important that we find a strategy that would work, as I say, in the real world. That is it feasible inside of routine practice and acceptable to the providers? And for the organization, is it feasible with management and the regulations and financing? Is it acceptable and consistent with the mission of the organization? And we're pleased that the products and what we've developed seems to work for both the clinicians and the organizations. Basically, the CarePath has a basic philosophy that rather than taking people with depression and singling them out and bringing in a different clinician, which of course is not very feasible, is that we basically have every nurse learn how to provide depression care management. And we talk to nurses about depression care management or clinicians in the context of all the other kind of chronic disease management they do. We sort of say, well, you have a patient who's getting wound care, but the patient has diabetes. You do divide diabetes management regardless of what the presenting condition is. And if there's congestive heart failure, you deal with that. If there's depression, you deal with that. It's, the mantra is it's just like every other chronic disease. And then we help provide clear signals of when a clinician should be consulting with someone with more expertise or making a referral. So not expecting that the clinician is going to be doing everything on his or her own. We talk about effective strategies for how to discuss depression with other clinicians and physicians. And I learned this one right on was we never ask nurses to give psychotherapy. I actually went to a trial that helped train nurses to give what's called problem-solving therapy, and it was just a complete disaster. It didn't fit in the time. They didn't feel their responsibilities, even those who volunteered. And it really said, this is not the job of the home care clinician who's going in and doing a lot of other things. But they should know about depression, should know how to manage it, should know when to consult someone, when to refer, and how to do that. Our strategy includes the protocol itself, and we also developed a lot of tools to help agencies implement it to make it fit. And again, here's the website. And there is an e-learning module about depression care management. And this is what the protocol looks like. Let's see, let's hope, yes. So again, we start with assessment. We really already began when we assess patients with a PHQ-9 at the first visit. And I think one of the very most important components of the protocol is that depression assessment is not a one-time thing. It's something that happens at the first visit, and we recommend basically doing it weekly or at the next visit weekly so that you can be monitoring depression severity and giving clues of when a patient that you're monitoring, when there's indications that there's something not going well, something, the score has gone up, suicide ideation has gone up. I think that one of I'll go back to what I said about physicians people who prescribe antidepressants and then don't follow up. Again, the biggest problem with depression care management is not following up, monitoring the symptoms over time. Try to find this. Sorry, my mouse is being annoying. All right. So besides assessment, then also knowing about coordination with other clinicians, especially depending on the guidelines of the agency, either how to contact the patient's physician about depression or another specialist. We've worked with agencies who want the clinician to go immediately to their clinical social workers and others to call the physician. We have in our e-learning modules some training and discussion about how is the best way to present depression to a clinician in a way that will be efficient and quick, but also heard and the physician will respond to. And then in addition to assessment and coordination is management, especially management of antidepressants, understanding of doses, adherence, side effects. There's training on that. And then patient education and family education, we have toolkits. And then helping patients with goal setting. This is not, again, we don't do psychotherapy, but like any assistance in goal setting, you really want to encourage patients who, for example, the reason they're not getting out of bed and brushing their hair has to do with more of a depression than any physical disabilities or illness, and to help them identify pleasurable activities, things they want to do. It doesn't have to be a big sit-down therapy session, but it is useful to talk to patients about have they called their grandchildren, what do they like to do. Excuse me, I'm going to find a different clicker. There we go. So again, here's the training on goal setting. So that's pretty much the components of the protocol. We want to build off the depression assessment that's already in the OASIS, to take patients who have screened positive, to give them a more thorough assessment to be able to evaluate the severity of depression and also suicide risk. And then for patients who score 10 or more on the PHQ, where it indicates suicide risk, to then start the depression care management protocol, where you're monitoring, you're assessing and therefore monitoring symptoms over time. You're coordinating the care and, with other clinicians. You're managing medications. You're helping with patient education, and you're doing some goal setting. Again, the website that we have, we've developed the e-training for the PHQ-9, and then the e-training for the Depression CAREPATH. And there's a lot of videos and resources in there to make it sense. We also have, as I mentioned, the suicide risk protocol and that agency protocol for how to make depression referrals and coordination, how agencies can make up a list, make sure they have a list of mental health resources. We have integrated this protocol into, I don't remember the last count, but it's around 6 different commercial software systems where with, in different ways with each system, so that nurses and other clinicians can be reminded or prompted, or at least recording what it is that they will be doing as part of the protocol over time. So again, it's not just the first visit, it's visits over time. So let me see. So this is my slide showing that the CAREPATH makes a difference in terms of 30-day and 60-day hospitalization. I think it's interesting that, as I said, the impact on depressive symptoms works over a long period of time, over the course of a year, but the impact on hospitalization risk is much more immediate. And I think that as far as we can tell, a lot of that has to do with both acknowledging that to the patient and the family that these mental health symptoms are real and they are something that can be assessed and managed and can be intervened on, and also involving other clinicians in recognizing that these symptoms are things that are clinically meaningful and need to be made aware of. I think one of the sadness over what used to happen is people were ignored or they were poo-pooed or it didn't make any difference. It's not a new thing at all for clinicians to say that they had to home health patients, knowing that there's a lot of home health patients who suffer depression, but I think that giving clinicians the tools to formally assess and be able to report in a way that can be interpreted and understood, and to give some management strategies has made a big difference for a lot of people. The HHQI, the BPIP, has a great deal of resources in it, and I really encourage you to take a look. They've got this beautiful framework for the depression zones that I think is really nice, and I'm just going to once again say thank you to the group for really working so hard, for pulling together evidence from not just our group. Obviously, there's a large number, well, not big enough, but a number of people who have been really working in the area of home health and depression and really have making contributions, and this resource pulls that all together in a really nice way. So I think that it's time for, I'm really very happy to take all kinds of questions, and I'm sure other people in the group will too. So thank you.
Thank you, Dr. Bruce. Please use the chat or Q&A feature in WebEx to type in your questions now, and we'll start with a few that have rolled in during the course of today's presentation. First question asks if the depression care path is appropriate for all nurses and not just specialized nurses.
I will, I'm sorry I didn't make that point clear enough. It was definitely designed for all nurses. And I know that when we started, the agencies that we were working with, most of them did not have any mental health specialty nurses, and some subsequently did. But our goal was, because there weren't enough specialty resources, was to say, well, what can all nurses do? I do know that some specialty nurses are using the CAREPATH quite successfully, and I also know agencies that have built their specialty program because they've had their med-surg nurses doing the CAREPATH and referring some of their patients to their specialty programs. So you could put it into place a lot of ways, but the strongest thing I can say is that this was designed for use by all nurses in the same way, as I said. Any nurse goes into med-surg nurse, community nurse goes in the home and sees a patient who is suffering, has an ostensible reason for being there, for having an injury, and also has diabetes. The nurse is going to pay attention to the diabetes in the same way we're asking nurses and other clinicians to pay attention to the depression. Thank you.
Next, we have a comment that came in from one of our participants on today's webinar who says, we like using a visual analog scale for patients where one exists that is evidence-based and validated, such as for heart failure or oncology. She says that we find that patients are more open to marking what is going on than answering questions verbally.
Oh, that's wonderful. Sort of like the thermometers that people use for pain and things like that. I think that's a great idea, and I think, I'm not sure if the one comes to the top of my head about what already exists, but I think we need to make one, and we'll go ahead and I'll go see, and I'll talk to the group, because I think you're absolutely right. I think in some cases patients would rather just write down something or score something. In other cases, some people don't frame how they're feeling in simple terms, and so sometimes questions can be very helpful. People may not be thinking of themselves as depressed, especially, as I said, some are could be irritable and they don't view themselves as depressed. They view themselves as angry, or they don't know what the feelings are, or they think they're normal, and so it can be useful to ask specific questions to get at what people are feeling. I know in our own work, when we would be talking with patients and we would ask them about thoughts about death in particular and wanting to die, and they would talk to us saying that they didn't want their family members to know this the way they were thinking. They never told anybody else, and I don't think they ever would have told anyone if we hadn't asked. So I think the visual analog is fabulous, and I think we should do that, and I also think that we should not be afraid to ask the questions. And I think probably the trick will be figuring out what's the best approach for each patient. So thank you. That's a great suggestion.
Next question asks, what do you recommend for patients with dementia who cannot answer the PHQ2?
Oh, that's very hard. The Cornell scale is made for patients with dementia, so we could look into that. The other thing, sometimes people will talk to family caregivers or people in the home and ask for their what they see or they perceive. I think it's always useful when you're asking about symptoms, as you know, is to ask for specific examples and not so that at least you have evidence that you can evaluate yourself about. So I don't have a very good answer because I think it gets harder and harder, but there is the Cornell scale, and I would ask family members.
Next up, do you believe or is there evidence that ADL decline precedes depression, or does depression precede ADL decline, or neither?
Oh, well, this is like I've done a lot of work on this, so this is my favorite subject, but there is evidence of both, that depression we have evidence showing that among people who are with no ADLs over the course of a couple of years, those with depression actually have real ADL onset disability. And we also have evidence that people with ADL disabilities and those who are homebound are at risk for first onset depression. And I think you put your finger on one of the biggest challenges, is that you have this cyclical situation where the ADLs and the depression, or the disabilities and the depression, are sort of perpetuating each other. And if we can, this talk was framed around breaking the chain around depression and hospitalization, but the chain between disability and depression is equally tight and really important to break into if we possibly can. So thank you.
Our next question says, a hospital that refers to our home health care agency does the PHQ2 almost upon admission for patients. Interestingly, we get very few scores indicating depression. Should we redo the PHQ2 on admission or later in the home health care episode?
Well, first of all, I think, as I said, I think that the PHQ2 is a really important tool because it gives us a language, but I also know that we don't get, as someone said about the visual analog scale, it's not really an easy question for people to answer, especially in a stressful situation when they're asked to sort of count up the number of times they've been feeling some way over the last number of weeks. So what am I saying? I'm saying that I would definitely do it on the first visit, bring it back home, do it in a more comfortable environment, and then really encourage nurses and other clinicians to ask the questions. Even if you take a look at our videos, and we really encourage nurses and clinicians to ask the questions in clinically meaningful ways, even if you know, to pause more, to look at what people are saying and not to rattle them off. I think if they're thought of as a clinical tool and not a survey question that you're getting on the telephone, I think you will get, it'll be more sensitive to people's needs and they'll be more comfortable answering. So that was a long-winded way of saying, yes, do it again, do it at home, but do it slowly and do it with kindness.
All right, next question asks, in the past, I have been told permission must be given to allow for use of the Cornell depression screening. Do you know if this is still the case?
You do not need to have permission.
Okay, next is
my best friends made it. If there's any blowback, I will let them know. But I know they encourage people to use it, so I think it's great.
All right, thank you. Next question, is depression teaching and management considered a skilled nursing need? So if a patient was recently diagnosed with depression and started on an antidepressant, can that be considered a primary diagnosis for home health?
I'm not the person to answer that one because the rules keep changing. I know that some agencies have done that, and so I think that someone else has to answer that question.
Okay. Next up, we have a comment that came in. This participant says, at our agency, all patients admitted to home care are administered the PHQ2. Patients scoring a 3 or above are referred to our behavioral health program for further investigation of depression using the PH9 scale and GDS scale.
That's great, and I think what's important about what you just said is that you have a response to patients who screen positive on the PHQ2. You know, the way I described this depression CAREPATH was that the nurse who's doing the 2 follows up with the rest of the questions and does the 9 right then and there, and that can be an efficient way to do it. But I know other agencies do exactly what you say, that they use the 2 as a first screen and use it to refer to their behavioral health specialist. It really kind of depends on the resources of your agency and if there is a behavioral health specialist program and how you want to do that. I think the important thing is that there's follow-up and that the information that's assessed is used in a clinically meaningful way.
We have another comment here from a participant who says, I was surprised with the slide that showed the duration of services, number of nurse visits, and the duration of RN visits were actually a little less with the use of the depression CAREPATH than usual care, as well as reduced hospitalizations. This was very interesting, and thank you so much for sharing it with us.
Yeah, we were really happy too. Thank you. And just to say, we've had anecdotally nurses tell us is that when you deal with the depression, other things get easier. And I think that would be the reason that all those things that you think would take more time would actually go down, or at least not get worse. So thank you.
In response to the multiple questions about handouts today, there are handouts of the slides available at homehealthquality.org under the Webinars tab and Depression. So you can view those on our website at any time. I think we probably have time for 2 more questions, and then I'll go to Misty Kevich for some more information. The first of our last 2 asks, how receptive were the clinical nurses in your trial with integrating the depression care path into visits?
Ooh, most were, not all were. Some were not real receptive until they started doing it, and they got much more receptive. I think over time, nurses are more willing or likely to say, yes, depression is a problem, and they're looking forward to ways of handling depressed patients. But I'm not going to say everybody was happy in the beginning. I think most people who did it were pretty pleased.
Okay, another question says, I was at a recent OASIS training when the teaching was indicated to mark not applicable if the patient could or would not answer with a specific answer to the question. Do you know if this is accurate? For example, when the clinician asked question 1, the patient did not answer from the days to select, but rather ad-libbed or provided a vague response.
Well, I'm a little confused by that question. So when this is for the PHQ2?
That's all we had. I'll tell you what, for the sake of timing, how about we'll follow up? Oh, actually, yes. The respondent said yes.
Well, it's certainly not applicable. I'm not sure. Let me think about how to respond to that question, because I think that's complicated. Thanks.
And our final question is a simple one, and this person asks, just to confirm that all of the Depression Care Path training is free to use, correct?
Correct. And we encourage you, it's a real pleasure that you use it. So yes.
Okay. Thank you so much, Dr. Bruce, for a great question and answer session. At this time, HHQI's Misty Kevich is going to provide us some more information on resources and continuing education. Misty?
Thank you so much, Shannon, and thank you so much, Dr. Bruce. So what we've done on the slides, and as Shannon told you where you could get those, and they're in the chat box, there was a link also to where to get the slides from today. But the Depression Care Map, we have a link that takes you to all the tools on their site. So we provided that for you. Also with HHQI University resources, Dr. Bruce mentioned the Depression Management Best Practice Intervention Package. There is a link that will provide you to the resource. There is also a course in HHQI University that's available for 3.5 hours of free nursing CEs for reading the BPIP and doing the activities that are included. And one of the activities and a resource for you is A Path to a Brighter Day, and it's Depression Signs, Symptoms, and Treatment. And it's a patient multimedia module, about 5 minutes long. It's ideal for you to play with your patient, for your patient to review, and it's just a multimedia approach to it that's going over signs and symptoms. It's actually integrating the PHQ2 within that course. So it's a nice way to present that to a patient. We also have that depression zone tool. So to receive this continuing education today, just for like most of our webinars, you need to go to HHQI University. So on the slides, we do have the university site embedded, but you will also be sent there after this presentation. And so you will need to go into the university. If you've never been there before, you will need to sign up for the first time. If you've been to the university site and you can't remember your username, reach out to us at hhqi@qualityinsights.org, and we'll look up your username for you. We like to keep one registration so all your courses are together. Then you'll go under the course catalog for disease management, and you'll find Break the Chain, Depression Links to Hospitalization course. You enroll by clicking on the little red apple, you click on My Account, and you will go ahead and click on the little green book to get started. And really, it's just simply you needed to watch the live or the recorded session. The recording will be available tomorrow on our site. And then just watch that 5-minute patient module just so you could see what it is, if that's a good resource for you, and complete a reflective question and evaluation. And when you've completed it, you exit and you will go to My Account area of the university and your certificate will already be there. If you have any questions with anything with the university or depression resources, please reach out to us at HHQI, qualityinsights.org. And Shannon, I'll turn it right back to you.
On behalf of all of our presenters today, Cynthia Pammon-Burnett, Dr. Martha Livingston-Bruce, Misty Kevich, and myself, we'd like to thank you for joining us for today's webinar presentation. Have a great day.